response to any drugs given to patients like ACE inhibitors or ARBs or any NSAIDs?
Anything else?
Transformation of the disease, sir. Like
And any drug. We
NSAIDs.
give diuretics commonly.
Sir.
They can cause interstitial nephritis also, beside causing.
Yes, sir.
That can be. Sit down. Mechanism of anasarca in nephrotic syndrome. Francis? Or you sit down. Major Sanjay, pediatrics. Major Sanjay.
Sir, initially starts from the proteinuria, as there is massive proteinuria, and because of that hypoalbuminemia, and since the albumin is low, which maintains the colloidal osmotic
Please
pressure.
be mic closer.
Sir, initially starts from massive proteinuria. Because of that,
So
there is loss
leads
of
to
protein.
hypoalbuminemia.
And since albumin maintains the colloidal osmotic pressure, that retains the volume within the vessels. So decreased colloidal osmotic pressure leads to, and along with increased hydrostatic pressure, that leads to edema. And mainly there's decrease in plasma volume that will activate.
So movement of fluid from intravascular to extravascular. That is what third. So this is known as underfill theory. You know about overfill?
Sir, this then activates the RAS pathway, because since the volume is low, the renin-angiotensin-aldosterone system gets activated, which in turn leads to sodium retention, thereby increasing
Can
the
you
volume.
be specific? What is the cause of overfill? Have you heard of underfill and overfill?
Yes, sir.
So what happens in overfill?
Sir, in overfill, since the volume is less, this thereby.
So in overfill, what happens is when the protein passes to the tubules. So there is a plasmin protein also, which stimulates E-neck channel. What is that?
Epithelial sodium activation.
Channel. Okay. So it blocks it. So there is no excretion and sodium retention is there. This is overfill theory. Sit down. So, continue.
On general examination, her weight was 84.5 kgs, height was 154 centimeter. She was afebrile. Her pulse was 94 per minute regular. Her blood pressure was 160 by 90 millimeter of mercury, right arm supine. Her respiratory rate was 18 per minute. Saturation of 98% at room air. She had anasarca, bilateral pitting pedal edema. There was no evidence of pallor, icterus, cyanosis, clubbing, lymphadenopathy, and her fundus examination was normal. On systemic examination, her abdomen was soft, non-tender, distended, with presence of shifting dullness. There was no evidence of guarding, rigidity, no palpable organomegaly, and bowel sounds were heard. Her respiratory system examination revealed absent breath sounds in breath over bilateral infrascapular and infraxillary areas. Rest of her systemic examination was essentially normal.
Continue.
On investigation.
Any biochemistry resident? Rajvinder, just interpret. HB is low. No.
Sir.
Beyond that.
Beyond that, sir, urea and creatinine both are raised, sir. And
suggestive of likely AKI, could be CKD, we'll see.
Then total protein is low, sir. That is obvious in nephrotic syndrome, sir. Albumin is low, and there is reversal of
What's the
AG ratio, sir. And
so Rajvinder, first of all, every nephrotic will have reversal of AG ratio.
Sir.
AG reversal. Please don't use this term for nephrotics.
Right.
AG reversal when globulin increase, then you suspect those myeloma, liver disease, chronic infection.
Sir.
So every nephrotic AG reversal would be there.
Right, sir.
So it's irrelevant. So serum albumin is 0.2.
Sir. Then lipid profile is again there is dyslipidemia in terms of total cholesterol is raised to 670, and HDL is low to 36 milligram per deciliter, and triglyceride is again raised to 440 milligram per deciliter. Again.
So why lab reports don't mention LDL?
Sir, LDL, sir, we are till triglycerides are 400 milligram per deciliter, sir. We calculate the LDL and then we mention it, sir. Otherwise, if it is more than triglycerides are more than 400 milligram per deciliter, in that case, sir, we directly measure the LDL and give the report, sir.
Is it
And
available here?
yes, sir, it is available, sir, but it is very costly test because there are two detergents
do.
used, sir.
So we do it rarely when asked for, maybe
Yes,
something.
yes.
Like that. Sit down. Any path resident? So what about this urine REME?
Sir, it's raised 3 plus, sir. 3 plus means, sir, the level of protein is, sir, 300 to 1000, sir, milligram per DL, sir. And it has been measured by the use of the dipstick test, sir, actually.
Very good. No RBCs, not mentioned. No, there were no casts out,
Yes,
so
sir.
no dysmorphic.
Sir.
So what does it mean? No RBCs. What are we ruling out?
So we are ruling out the, sir, hematuria, sir, micro on nephritic syndrome
Very good.
kind of thing, sir.
Okay, kind of thing. No. Wait. Go back. So next. This also interpret 24-hour urine report.
Yes, sir. Sir, the volume is, sir, this protein is, sir, 1627 milligrams, sir, in 24 hours, sir, in a volume of 500 ml, sir. So it is a protein is in that is also measured by the same method, sir, the urine dipstick method, sir. And
Protein is measured by same dipstick method.
sir, the two methods are used, sir, mainly,
For
sir.
24-hour, which method do you use?
Sir, by adding of sulfur salicylic acid, sir. Sulfur salicylic acid, sir.
At least not dipstick, no?
No, sir.
Huh.
Sir. And then the creatine.
Why are we asking for creatinine levels?
For measuring the UPCR, sir, urine protein creatinine ratio, sir. And
There
if it is more than 3,500.
And there is one more reason. Yes, you are right. One more reason for measuring creatinine.
Dilution, sir, for checking the dilution, sir. Because
Any other path resident can answer? No.
Sir,
Sit down, sit.
we use the creatinine to check whether we have to compare it against some of the normally secreted substance in the urine, sir. That is
So to
creatinine.
check for adequacy. So
Adequacy.
females muscle mass is lower, so it is 10 to 15 milligram per kg in 24 hours, and males 15 to 20.
Sir.
Sit down. Any radio resident? Radiology? So ultrasound, X-ray, okay, bilateral pleural effusion we expect because of.
Yes.
What about ultrasound?
So ultrasound, the renal length has been written as the right kidney is 12.2 and left is 12.9. In general, adults, a renal length of 9 to 13 centimeters is normal, but she's a 16-year-old female, sir. So I'd like to go and.
So what's your name?
So I'm squad leader Kailash.
Kailash.
Yes, sir.
So I'm not sure what 9 to 12 centimeter is taken, but maybe different in your textbook. And you said ki she is 16-year-old female. So we expect her size to be smaller.
In general, sir, renal length corresponds to the body habitus as well, particularly height.
So anyone, are you sure by what time the kidneys reach the adult size?
Adult size, I think by 12 years.
Anyone differs? Any resident, medicine resident, pediatrics? So they reach adult size by 9 to 10 years of age. Okay. So 9 to 12. Anyway, her kidney size are larger. Why? Because of nephrosarca. Simple. And you have mentioned normal ecotexture and CMD. How do you look for ecotexture?
In general, sir, we compare the renal cortical ecotexture with that of the adjacent liver or the spleen. If
Mic
it is,
closer.
we compare the renal cortical ecotexture with that of the adjacent liver or the
Liver and spleen.
If
If it is increased, what does it indicate?
If it is increased, it is a sign of any renal parenchymal disease, sir.
Very good.
that
And
is-
what about CMD?
We look for the differentiation. Usually the medullary pyramids are hypoechoic compared to the renal cortices. And if this differentiation, if we are not able to make out the difference between the renal cortex and the pyramid, again, it is an indicator of a renal parenchymal disease. That is
Yes.
a medical renal disease.
So we are trying to rule out CKD at least.
Yes, sir. So in
Kidneys are
CKD,
normal,
we
rather
expect,
enlarged in size.
Yes, sir. In CKD, we expect small atrophic kidneys with loss of.
Thank you. Thank you. Sit. So what are the differential diagnoses? Rajesh?
So at this stage, we have a diagnosis of differential of nephrotic, sir, because she is fitting into nephrotic ring proteinuria. She also
And
has
your-
hyperlipidemia.
Nephrotic syndrome.
Sir, nephrotic.
AKI is there? Or is it CKD now?
So not CKD because of
AK.
ultrasound being normal. AKI is there, sir. Her creat is 3.6. But she fits into the criteria of nephrotic syndrome as per the
Nephrotic syndrome with AKI.
Yes, sir, with
Nothing has added up. What we were expecting, what we thought of after history, it is same. Nephrotic syndrome, he said ki MCD biopsy report was there.
Sir,
Documented report was not there. So cause is likely MCD only?
Sir, unlikely to be in MCD, sir. It can
Why?
be so because she had multiple relapses in the past. She has seen multiple therapies. So it could be it could be a steroid resistant MCD or it could be a FSGS, which was
Could
missed in
be
the early
FSGS,
diagnosis.
but what, sit down, Rajesh. Dr. Chandan, pediatrics. In MCD, what is the normal course? A child presents with MCD. What is the usual course of disease?
Sir, MCD usually child are steroid sensitive, sir.
Yes,
And
most of them, 80 to 90%. Yes.
sir, and age of onset is usually 3 to 5 years, sir. And
3 to 5, she had it at 9 months of age.
sir,
Okay. And what
And,
happens by the time they become teen or young adults? Usually it resolves. Okay.
sir,
Sit
secondly,
down, sit down. So urine dipstick has been discussed. Again, Akash or battery? I think you have not answered. Which is best?
24 hours.
We do everything, spot UPCR, ACR. ACR, albumin is always the best, but
Sir,
it's not commonly available.
Sir, as per Harrison, screening test for any patient approaching with AKI or CKD, the screening test is spot UACR is better than spot UPCR. However, the entire among the best is
Yes,
like
ACR, that it is always better, but
Sir.
not commonly. Out of these mentioning protein, which one is best?
the 24-hour urine protein, urine albumin is better, sir.
Again, albumin is yes, but out of where the protein is mentioned, is 24-hour urine protein is better, spot UPCR is better, or 24-hour urinary protein creatinine ratio is better?
24-hour urine protein creatinine ratio is better, sir.
Ratio is better. Okay, very good. Okay, so that you should monitor after 1 month when the patient comes, whether it is 3.5 gram per gram, it has reduced to 2. It is the best. Sit down. Continue.
she was started on supportive management with salt restriction, high protein diet, albumin loop diuretic infusion, and other classes of diuretics, and prophylactic anticoagulation.
Okay, salt restriction. Ashok, how much salt restriction?
Sodium and sir,
Take mic then. So
sir,
everyone can
less
hear.
than 2 gram of the sodium, sir, and less than 5 gram of the NaCl, sir.
Okay, so how do you ensure that?
Sir, we sir,
Patient को क्या बोलोगे?
sir,
What will
1 spoonful.
नाप के खाना बनाए? What about
Sir,
hospital?
no added salt and no pickle and bakery items.
No added salt, है ना? Salt to be added only in cook, not to be sprinkled on salad, not to be added in curd. No processed food. No processed food that includes biscuit, anything. Okay, cakes also. And what about protein? How much protein will you advise?
In sir, protein, sir, 1.8 to 1 milligram, 1 gram per kg, sir, 1 day, sir.
Okay.
And if urinary loss is there, sir, then we can add
Some more, up
per
to
gram.
5 gram. Sit down. What is so many diuretics were used? What is Ravi Sarwal? What is sequential nephron blockade?
Sir, it is a strategy to remove sodium from the body. So there are many places where sodium is reabsorbed. So we use different kinds of diuretics which acts at that level, and we can remove the sodium, sir.
So which
So
one
if
acts
we-
at proximal?
So proximal is we use diamox or acetazolamide,
Yes.
where carbonic anhydrase is inhibited. Then in